Hi everybody. Here is the one of the installments of the respiratory lecture. This one is going to be fairly brief on respiratory infections. Upper respiratory tract infections include pneumonia. The ones I'm going to talk about specifically today will be pneumonia and TB. Pneumonia. Sixth leading cause of death in the United States, especially in older people. And the prognosis really depends on the type of pneumonia. If it is a community-based pneumonia, more likely to be strep pneumoniae. Strep pneumoniae does carry with it a fairly high mortality rate. I thought I had maybe the number, what that percentage was, but a significant death rate, partially because in the elderly there's decreased vitality. But community-acquired pneumonia can also be caused by mycoplasma and Haemophilus influenza as well. Hospital-based or nosocomial infections. Nosocomial means acquired while in the hospital. Includes Pseudomonas, Staph aureus, and Klebsiella. And then there's other types as well, pneumococcal pneumonia, and then viral pneumonia. Viral pneumonia is what we know as walking pneumonia. This is usually self-limiting, but the issue with it is it destroys the ciliated epithelium and gets replaced, or the cilia are lost, and therefore decreased ability to expel. So you lose one of your defense mechanisms, and that predisposes to further infection. In the process of pneumonia, what happens is we acquire, usually by respiratory droplets or some sort of exposure, respiratory exposure, acquiring that pathogen. And we have mucus for that reason, that mucus to as a defense mechanism. And there are secretory IgA antibodies in the upper respiratory airways, and other mechanisms that we talked about, those first lines of defense, if you will, which help us to overcome the pathogen. In a healthy individual, that usually happens. Either that, or else we get an upper respiratory infection that's usually self-limiting. However, in immunocompromised people, in people who are reclining or bedridden, or in some other way, have a decrease in their vitality, decrease in their immune response, they become overwhelmed, and the pathogen migrates to the lower respiratory tract, and there creates an exudate. The exudate, which lines the alveoli and fills the alveoli, in which we would call consolidation, and then cavitation is when you get destruction of the septae, the walls, and just fills up with an exudate. Along the process, there's an inflammatory process that accompanies this the pathogenic invasion, and therefore we have a attraction of neutrophils, macrophages, other inflammatory mediators, including red blood cells, and the red blood cells are what actually the lung tissue fills up with red blood cells because of the destruction, and this is known as red hepatization. It's sort of hepatization, meaning it looks like liver, sort of looks like uncooked liver. If you might imagine that, that's what the lung tissue looks like. Not so conducive for airway exchange. But over time, loss of more of those acute cells, and we get an increase in cells with chronic inflammation, fibroblasts, and therefore we get more of a fibrinous exudate, that white, a white exudate, and then that accompanying that is the accumulation of fibrin or clotting tissue, and that process, and a loss of the red blood cells at this point, and this is now known as gray hepatization, or what I like to call looking more like cooked liver. You'll probably never eat liver again if you ever did in the first place. So this is the process on which the lungs get consolidated and develop this fibrous tissue, losing gas exchange, increasing therefore the work of increasing the pulmonary hypertension, therefore increasing the activity or the need for a stronger work for the right heart, and therefore that's congestive heart failure or heart failure soon ensues. TB, tuberculosis, about 10 million people affected in the United States. It kind of comes and goes. We have periods of time when more people are indigent and people are not taking good care of themselves. Their immune systems are lowered, and this increases the infection rates for TB. Keep in mind, because it's people who don't take good care of themselves, who are the ones that have it, they don't follow up on their antibiotic prescriptions, and about 15%, 15 to 20 now, of TB those infected with TB are antibiotic resistant, and that is a real concern. Mycobacterium tuberculosis is the organism responsible for tuberculosis. It's an airborne organism and lodges more commonly in the upper lobes and causes an inflammatory reaction. And what happens is your body is wise, and it surrounds the area of infection. Surrounds the mycobacteria and creates this what's known as a tubercle, an inflammatory collar, if you will, around the area of infection, filling in with fibroblasts. So this very difficult or tough wall, and therefore in the center of the tubercle, you get that necrosis, or if you'll remember, that's that caseous necrosis or cheesy necrosis, and which is a form of liquefactive and coagulative necrosis. Sorry, forgot. The two of those in combination causes that cheesy material to develop in the center of the tubercle. Another word for those tubercles, once that Swiss cheese-looking lung, is called a Ghon complex. G-H-O-N is the tubercle with necrosis on the inside. And that's what you see on an X-ray. That will become the bacteria that are housed in those macrophages on the inside of those are dormant, and when a person becomes elderly or immune compromised in some way, further compromised, you can get reactivation of the disease at a later time. And I think that is the end. So good luck to you on the test, and you'll be seeing me in the other sections, perhaps, depending on the order in which you looked at these.